Mumbai or Delhi?
Delhi, sir. So our head office is in Delhi. So
okay, and you are basically from?
So I'm basically from Aligarh, sir. I did my medical from AMU, Aligarh Muslim University. Yes, sir.
I went there around I think 7-8 years back. They invited me to give a lecture during the UP Diabetes Association conference for diabetic foot and whole.
Yes, sir.
Yeah.
So, sir, Ajay, just let us know when can we start.
Presently, Mankind is in top 10 pharmaceutical companies in the country.
Sir, actually in top 5.
Oh, top 5. Great.
With your blessing, sir, definitely.
But one very important with the Mankind, you are providing the most of the medication on the very subsidized prices.
Yes, sir, that has always been our vision to provide at the economic cost.
Even with that, if you are in top 5, it means the prescription wise, I think you are much bigger. Might be number 1 if you'll say that.
Sir, actually, sir, we are number 1. My brand manager, Mr. Visha, she will be sharing about Mankind journey just in a while. So prescription wise, yes, sir, we are number 1. And value wise, yes, we are in top 5. Sir.
Yes, because
pantoprazole. You can start now.
Yeah.
Okay. Okay. Visha, over to you.
Thank you, Dr. Prashant. Am I audible?
Yes.
All right. A very good evening, everyone. I, Ravisha Rana, on behalf of Mankind Pharma, would like to welcome all our esteemed delegates who have joined today us for our session of foot care and diabetes. I would also like to take this opportunity to welcome our esteemed speaker of the evening, Dr. Ghanshyam Goyal. Before starting up the session, I would like to take this opportunity to take you through the journey of Mankind Pharma in this pharmaceutical industry so far. Mankind Pharma has completed 25 years in this industry and are still counting. At Mankind Pharma, our vision is to become the most admired Indian pharmaceutical company. We have always believed in the philosophy of serving life, and we have always lived up to our values of the name of Mankind. I would like to take this opportunity to salute all of you for being the real heroes in this pandemic outbreak. Like I said, Mankind's philosophy has always believed in serving life, and we do not only believe, but put it in our work as well. Just as an example, in this pandemic outbreak, every employee of Mankind Pharma has donated their one-day salary in Prime Minister's Care Fund. Mankind, when we talk about its position in the market, as per prescription per month, we are ranked number 1. Value-wise, we are ranked number 4 because Mankind always believes in providing the most affordable medicines in the market. Mankind has been successful in establishing its presence in 34 countries, including United States of America. Not only this, Mankind has 19 world-class manufacturing units, which are WHO, GMP, and US FDA compliant. Mankind has always believed in their quality of improving the life of a person, and for that, our 3 basic fundamental pillars have always been quality, affordability, and reach. Mankind has been successfully able in these 25 years to establish its presence across all the therapy areas, starting from anti-infectives to urologicals. And not only this, among all these categories, Mankind stands number 1 in most of them. Mankind has its own research and development center where major focus is being done on new drug delivery system, active pharmaceutical ingredients, formulations and development, along with biosimilars. With all this, I would again like to thank everyone who has been associated with us in making our journey a success so far. I would again like to thank you for your continuous support and encouragement to us. With this, I would again extend a very warm welcome to everyone who is present here with us. And thank you so much for being with us today. Dr. Prashant, over to you.
Thank you, Lavisha. And now it's my privilege to introduce you to our esteemed speaker of the evening, Dr. Ghanshyam Goyal, sir. Dr. Ghanshyam Goyal, sir, is a director and head Department of Diabetology at ILS Hospital, Salt Lake, Kolkata. He is head Department of Diabetology at SVS Marwadi Hospital, Kolkata. Secretary for Integrated Diabetes and Endocrine Academy, IDEA. He's been past Vice President and past Secretary of Diabetes Food Society of India, life member of API, RSSDI, DFSI, member Diabetic Food Task Force of RSSDI and Diabetic Food Study Group of EASD. He has been regional faculty to Public Health Foundation of India also. Next slide, please. Dr. Goyal started the first diabetic foot clinic in Eastern India back in 2000. And it was first center in India to implement Project Hope, which is India Diabetes Educator Project. He has presented papers in various national and international conferences, conducted several workshops on diabetic foot all across the country. He has been principal investigator in various phase 2, 3, and phase 4 clinical trials. He has been author of a famous case study in diabetic foot, which was published in 2014. He has edited a book titled Emergencies in Medical Practice, and for his services, he has been awarded as Excellence in Diabetic Foot for 2018 by Diabetic Foot Society of India. Now, without taking much of the time, I hand over this session to Dr. Ghanshyam Goyal, sir. Welcome, sir. So your microphone is on mute. Yes, sir.
Thank you, Prashant, for your kind words. Diabetic foot, we all know, is one of the costliest complication out of all the diabetic complication. And mortality following diabetic foot is more 5 years mortality than 5 most common cancers. That is CA breast, CA prostate, lymphomas, lung cancer, all. And the cost of treatment of diabetic foot is also more than the 5 most common cancers. So with this background, we'll start with a workshop pattern in diabetic foot. So this is a fact which we all know. Over 1 million amputations every year across the globe. In India, around a lakh of amputation every year, but there is no amputation registry, so it is very difficult to say, and probably these numbers are underestimated. And every 22nd, a leg is lost to diabetes somewhere in the world. And very important, the incidence rate of diabetic foot ulcer is around 34%, which we used to say around 15 to 25%. Now it is 34%. And throughout the world, up to 70% of all leg amputation happen to the people with diabetes. In India, the biggest problem with we have got a very few organized diabetic foot screening programs, lack of podiatry services, because in US and in the UK or European country, there is a podiatry services are there, and there is a course, 4-year podiatry doctor course is there, which is lacking in our country. And the multidisciplinary team approach is lacking in our country, because diabetic foot management is a multidisciplinary team approach. And very important, diabetic shoes and orthotics are not available even at the metro cities, forget about the district towns. And barefoot walking, use of Hawaii chappals, lack of touring by married women, or lack of awareness to the seriousness of diabetic foot problem, both in physicians and patient community. So with this background, I'm going to show you 5-6 cases, and then we'll discuss, and then of course we'll discuss the cases also, how you'll manage the basic principles. So 40 years male, hypertension, non-smoker, obese, BMI was 35. Just a minute. So you see, and non-healing neuropathic plantar surface, because it is in the plantar area, and you see there is a callus around the ulcer, so it looks to be neuropathic ulcer. Since last 3 years, ulcer is a huge one. Then this is the second case where you can see patient is having multiple ulcers on the plantar surface. One here, another here, you see, and history of barefoot walking the temple during the hot climate, followed by blister and non-healing ulcers since last 5 months. Then type 2 diabetic, 20 years, hypertension, hypothyroid, tobacco addiction. Very important. Whenever you find a patient who is having, you are suspecting that he is an ischemic ulcer, then the consumption of tobacco in any form, smoking or jarda or this masala, it's addiction. With blackening of third toe of right foot, you can see that blackening, and with severe pain. In neuropathic foot, there will be no pain, but in the ischemic foot, there is a severe pain. Also on the lateral border of the great jaw. Here you can see the lateral border of the great jaw, and history of traumatic injury 5 months back. Another case, hot and swollen right foot and ankle for 1 month. You can see the differentiate is the left and this right one. So you can see swelling of the ankle and the foot. Admitted outside, treated for cellulitis, and no history of trauma, cause was not known. Then another case, 60 years female, presented for the first time with infected ulcer covering the entire dorsum of the right foot. You can see entire dorsum of the right foot. History of injury to ankle 15 days, followed by hot back compression. So in all the diabetic patients, we always say, please do not do the hot fomentation, which is the most common practice. So with this background, with these cases, I'll try to discuss all these. So first, I'll discuss a bit about the pathophysiology. You all know about diabetic foot. Now people are more and more aware of the diabetic foot, and due to the lot of workshops, conferences, all, and of course the credit goes to the DFSI, also Diabetic Foot Society of India, who have spread the message across the medical community across the country. Then what is the burden of diabetic foot? Already we have evaluated. Then neuropathy evaluation, vascular evaluation, then classification of foot ulcers, offloading tactics and management principles, and then case discussion. So before going to that, I'm just going to tell you 3 basic principles. Always remember: adequate debridement with infection control, 1, then adequate vascularity, 2, and 3, adequate offloading or proper offloading. If these 3 will be done, the most of the ulcers are going to heal. And in our country, most of the patients who are having the diabetic foot ulcers, around 85% are neuropathic, while rest 15% are ischemic. While in Western world, around 1/3 are neuropathic, 1/3 are ischemic, and 1/3 are neuroischemic. So that's the pathophysiology of neuropathic ulcer: motor, sensory, and autonomic, muscle wasting, deformity, stress, and trauma and ulcer formation. Sensory, then the stress bonds, callus formation, this is there. And autonomic neuropathy, reduced sweating, AV shunting, dry skin, increased blood flow, fissures and cracks, and bulging of foot veins of warm foot, and infection ultimately lead to all this. So neuropathy in the form of sensory, motor, and autonomic all lead to the ulcer formation. While over the peripheral arterial disease, atherosclerosis narrows the block, the arterial lumen. Foot ischemia, foot ulcer, maybe necrosis, gangrene, infection, and ischemic toe due to atherosclerosis. This one. So this is a very famous statement by the Swartz around 100 years back, or more than 100 years back: no acid, no ulcer. Then after 100 years, another famous statement from the Groblers, that no ulcer, no amputation. So remember, it's a very important. Then 2005, 15 years back, position statement of the IDF, International Diabetic Federation, was that diabetic foot amputations are preventable. And the approach was to reduce the amputations by 50%, but we are not at the goal. So how you will approach? Remember it, I'm going to discuss each and everything with the practical approach, not the theoretical basis, because whenever I conduct any workshop, people are happy. If I will give some lecture, they say, we know each all, but how to do it? So that's why I'm trying to do it in a practical basis. Assessment, history and physical examination, lab measures, classify the ulcers, then management principles. Very important. Priorities of physical examination in non-diabetic subject, head to foot. When in our, from the MBBS days, medical school days, we start examination from head to foot, but in diabetic subjects, in Sanskrit, apadamastak means foot to head. So whenever a diabetic patient comes, please start your examination from foot to head, so you are not going to miss the foot. So foot examination is a priority in diabetic subject. I think this is the message which I want to convey all of you. Then remove the shoes and socks and examine the foot every time you see someone with diabetes. It is a famous legendary physician Paul Brand in 1980, around 40 years back, when he was asked at the ADA how to reduce the amputations, then this was a statement made by him. So it still hold true. To reduce amputation, you have to remove the shoes and socks and examine the foot. So this is the, I think everybody see in your clinical practice, what is the typical presentation of foot in your clinic. This is the neuropathic unilateral ulcers. Always remember, I'm going to discuss what is the neuropathic ulcer and what's the ischemic ulcer or neuroischemic ulcer. Nail prick, non-healing, 3 months. Mechanism on injury, injury not known. Rat bite, it's very common in our country, and the rat bite leading to amputation. Then heel ulcers heal very difficulty, remember it. And this is a classical huge ulcer, more than 5 years. This is a lot of callus, and to have a callus you need a good blood supply, so that's why it's a neuropathic ulcer. So this is there. Then nail prick while bathing in Ganga, non-healing ulcer more than 2 years. Then again, neuropathic ulcer, maggots. These are infected maggots, and maggots, we know these are very good debriding agents. These are there which are present. Non-healing ulcers, mechanism of injury not known. Third, empty head ulcer more than 10 months. This is a common presentation we all come across in our clinical practice. Most important is a bilateral neuropathic ulcers. You see great toe ulcers, and remember it, 1/3 of the ulcers which are present in diabetic foot, it is on the plantar surface and the great toe. Remember it, neuropathic. And then the first, empty heads. This is also one of the very common area where the ulcers occur. And very important, remember it, to offload unilateral foot is easy, but to offload bilateral foot is most difficult job. History of foot foundation and leading to this sort of ulcers, and that's why in neuropathic ulcer foot, where the loss of protective sensation is there, we always say to avoid foot fermentation. Then non-healing 6 months ulcer with a history of chemical burn. This is what he use the nila thuta, copper, blue copper, what you say, copper blue, they use to relieve the pain, and that lead to this problem. Then ischemic trauma carries injury, then application of compression bandage without assessing the vascularity and lead to gangrene. Habitual smoker, blackening of since 3 months, and with the gangrene, the patient was underwent peripheral angioplasty, and then the things happen. And this is the infected foot. We see it's a limb to life-threatening infection. Here we have to go for a major amputation, below knee amputation, to save the life. So these advanced cases you all come across in your clinical practice. Again, walking barefoot to temple, this is a very common practice in our country. This was a scenario, and landing with this, and needed the skin grafting in the after 3 months when patient becomes stable. These are the reasons. So there are 2 rules in diabetic foot. One is rule of 15, another is rule of 50. 15 means 15% of diabetic foot ulcers in lifetime, but remember it, now it's 34%. And out of that 15% of foot ulcers become osteomyelitis, and out of that 15% have lead to the major amputations. And tragic rule of 50, this is really tragic. 50% of amputations are below knee or above knee, is a transfemoral or transtibial. Out of these 50%, second amputation occurs in less than 5 years, and out of these 50% die within less than 5 years. So remember it, the mortality of diabetic foot ulcer is more than 5 most common cancers. So with this background, examination of foot is an integral part of physical examination of every diabetic patient. So there are 2 things in your busy clinical practice. Just give 30 seconds. So what you'll see, any previous diabetes related foot problems, are both foot pulses palpable, especially what you will like to see, the foot pulses are palpable or not. And the most common foot pulses are dorsalis pedis and tibialis posterior. is protective sensation intact or loss of protective sensation there or not, and is there any significant foot deformity? By just asking the patient to remove the shoes and socks and do a 30-second foot examination. If you find any significant thing with the 30-second examination, then then 2 minutes examination is there. So go for the 2 minutes examination. And what happened? My computer is stuck. So what happened?
You can unshare and then share again, I guess.
Yeah, I stop sharing. What happened? So again, share the screen. Just a minute. Just a minute. Again, I'm stop sharing and going to back to the. Just a minute. Yeah, sorry for this technical glitches. So 2 minutes foot examination, examine the toenail, foot for ulcer, callus, blister, maceration, skin cracks, identify nature of any foot deformity, and very important, observe the patient's ability to perform foot care and examination by observing them, replace shoes, socks, and shoes, and explain need for the foot education. Then by doing a foot examination, what goal should be identified? Is it a normal feet or feet at risk? There is a presence of significant neuropathy, means LOPS is there, and presence of significant ischemia or presence of foot lesions. So risk categorization, low risk, no sensory neuropathy. You have to ask the patient to have a comprehensive foot examination once in a year. Then high risk sensory neuropathy or loss of protective sensation once in every 6 months. Then sensory neuropathy plus signs of PAD, peripheral artery disease, or foot deformities once in every 3 months. History of previous ulcer, history of Charcot's foot, history of previous amputation once in every 1 month or 3 months, and whenever it's needed. So these are the again same sort of how you'll go for it. The risk category 1, 2, 3, 4. So these are the high risk foot. You can say callus, generally it is on plantar surface, then the foot deformities, then the history of ulcer and the peripheral vascular disease. So you have to take history just like medical history: tingling, numbness, burning of feet, previous foot ulceration, amputation, use of tobacco, claudication, pain in legs, difficulty in walking, association with vision loss or chronic kidney disease, because the prognosis in CKD is worse than anything. That's why we call it as the renal foot. And you always remember to examine the footwear of the patient, because footwear might be sometimes the cause of the foot ulcers. If there is a foreign body inside it, or there is a worn out or narrow toy box or high heels, then it is very important to examine the footwear. And we have found in one patient there was nail prick, nail was there inside the footwear, and that was causing the persistent this infection and the ulcer. So this is very important to examine the footwears. Then to inspect for nail, the onychomycosis very common. Then you have to look for foot deformities, and you just see the infection, very severe infection on the dorsum of the foot, and is a moderate grade of infection. Then is the fungal infection of nail, and then the deformity. And this you can see again, this is the plantar surface ulcer with a lot of callus, foot deformity, positive surgery, and this Charcot's foot. You can see Charcot's foot. I'll discuss a bit about the Charcot's foot also. Then callus and hematoids. Callus is most commonly present over the first great toy, first, third, fifth empty head and heel area. These are the common areas because these are the high pressure area. This is the bunion, and you have to look for all these deformity. Charcot's foot, and then abscess. You can see a dorsum abscess in the foot. Long and deep fissure in the heel. These are very common. You have to look for it, and because these might lead to the amputation if you not heal properly. And always examine the interdigital spaces. So interdigital mycosis is very common. In Bengali, Dr. Amar Haja hoyeche, just like that. So you can see it. And paronychia. These are the most common sort of infections which are present. And you see, this was a patient who had non-healing ulcer since more than 5 years. When we have done the X-ray, then there was no bone practically. It was extensive osteomyelitis. So we have to sacrifice the great toe. In all the instances, it is always better to avoid amputation of great toe because it carries value in the walking cycle or in the weight bearing. So we avoid amputation of great toe, but in this situation, we are unable to save the great toe. Then how you differentiate? Is a neuropathic foot or ischemic foot? As I told that in India, around 85% are neuropathic and 15% are ischemic or neuroischemic. As a well perfused, both the pulses, dorsal pedis and tibialis posterior are bounding. Then high as claw foot plantar callus is there because it requires a lot of blood supply to have to grow the callus. In case of ischemic ulcer, there will be not of much of the callus will be there. It's a wet and infected gangrene. While in ischemic, it is a dry gangrene, and it lacks protective pain sensation, means LOPS. Patients are in big ulcer, they are walking, there is no pain. So about the neuroischemic, it's cold, it's not pink, it's generally black. It's a pulseless, marginated ulcers, and it's not May. It is very painful. Patient come, doctor, do something. I have got severe pain. So there is a pain. And palpation is very important. Always palpate for both pulses, the dorsalis pedis and tibialis posterior, and look for the temperature difference on the dorsum and plantar surface and contralateral foot. Very important. You have to examine and look for the limited joint movements are also important. In neuropathy evaluation, the gold standard is, I can say, monofilament test, but one neuropad, tuning fork, biothiometer, pinprick, temperature perception. This is their hot calls. So this is a very simple visual indicator test, which use a color change to define the integrity of the skin, sympathetic cholinergic innervation. You see, normal response, conversion of indicator pad from cobalt blue to pink in less than 5 minutes, but even at 8 minutes, blue become blue. So it means patient having neuropathy. This is known as neuropad, and it's available in the 300 to 400 rupees test. But most important is the neuropathy evaluation monofilament. So you have to buckle this should buckle at, you have to check a great toe, first, third, fifth empty head, heel area, and dorsum of the foot. But now recent guidelines on IWGDF, International Working Group of Diabetic Foot, only 3 means great toe, first empty head and third empty head. Out of these 3, if at 2 places patient is unable to feel the sensation, it means patient is having loss of protective sensation or using sensory neuropathy. And you can have the biothiometer. If it is more than 25 volts, then it means patient is at high risk of developing diabetic foot ulcers. About the peripheral vascular disease, in addition to proximal lesions, always remember that it may involve from iliac veins to the dorsalis pedis, but infrapopliteal vessel involvement is more common. Trifurcation at the level of this anterior tibial, posterior tibial, and in the fibular artery or peroneal artery. So for peripheral vascular disease in diabetes, Fontaine classification very simple. Stage 1 asymptomatic, stage 2 mild claudication, stage 2 claudication distance greater than 200 meters, stage 3 rest pain, and stage 4 necrosis or gangrene of the limb. So how you will diagnose the peripheral vascular disease? Clinical symptom, that is claudication. Actu hatle amar byatha chole ashe. Then clinical signs, examination peripheral pulses, and bedside test is ankle brachial index. ABI is the key to early detection and management of peripheral arterial diseases. So these are the few ABI reports which I am going to show you. ABI is a non-compressible arteries more than 1.3. Then you can see these are the calcified arteries. They're very important in diabetics and long-standing diabetes. These arteries are calcified. You can see both arteries are calcified. This is dorsalis pedis and tibialis posterior. These are calcified, you see, and that's why there is medial sclerosis, so Monkberg's sclerosis, and these patients will ABI more than 1.3. So always remember. So this is a non-compressible artery, but adequate toy pressure. Toy pressure, you can see is the 0.81. The toy pressure more than 0.7 means patient has adequate perfusion. Bilateral disease, where the ABI is less than 0.45 on the right and while 0.69 on the left. And this is the normal, where the ABI is 1.15 and 1.18. So how to interpret the ankle brachial index? When the ABI in between 0.9 to 1.3, it's normal, 0.7 to 0.89 mild, 0.4, some say 0.5, 0.69 moderate, and 0.4 severe or critical. On non-compressible vessels, when it is 1.3, more than 1 point. So what is the contraindication of ABI? One is excruciating pain, patient is in severe pain, then you should not do. And if you are suspecting that patient is in ankle brachial, patient is in deep vein thrombosis, DVT, in that situation, we should not do. Or severe pain associated with lower limb extremity wounds. Then toy pressure, and toy pressure is normally 30 millimeter less than the ankle pressure. We all know the ankle pressure is more than the brachial pressure, and toy pressure is approximately 30 millimeter less than the ankle pressure. Abnormal TBI is less than 0.7. Further evaluation, if you find any problem in the ABI, then you can go for a angiography, CT angiography, or MR angiography. Duplex color Doppler is a very good tool. You can repeat it multiple times, a non-invasive technique, and you can look into it where the block is. About the transcutaneous pressure of oxygen, this is one of very good tool, but it's a costly machine. It costs more than 10 lakhs of rupees, and it is very important. The predict probability of ulcer healing. Normal values are more than 60, and wound healing is more than 40 is likely. If it is less than 20, these ulcers are not going to heal until unless you revascularize. Then this is the PVD, you can see CT angio, baseline investigation, the creatinine is normal, then we perform the the CT angio, and if you find the blockade, then definitely we go for the procedure, either a balloon angioplasty or you can go for a pedal bypass. But nowadays, balloon angioplasty is preferred because morbidity and mortality is very less than in comparison to the pedal bypass. Then after neuropathy, ischemia, then comes the diabetic foot infection. It's a serious clinical problem. Properly managed, most can be cured, but many patients undergo amputation because of improper diagnostic therapeutic approach. Presence of infection worsen prognosis in diabetic foot ulcer. Clinical situation can often become limb or life-threatening rapidly. This is very important, so always remember. Microbiology of diabetic foot, remember it, polymicrobial, serious infection, hospital patients are often caused by 3 to 5 bacterial species. Aerobes, gram-positive, most common is staph, then the streptococcus, and then the gram-negative bacilli. And remember it, the Pseudomonas is uncommon. But if the grade of ulcer is higher and having ischemia and having multiple antibiotics in the past, then probably the Pseudomonas may be there. But Pseudomonas is in very less common in diabetic foot infection. Signs of infection, we all know during our medical schools, we have gone through redness, warm, swelling, tenderness, purulent or non-purulent secretions, discolored granulation tissue, undermining wound edges, foul odor. These might be absent also. Very important diabetic foot infection, because due to neuropathy, patient may not have pain, patient may not have secretions, it is deep-seated abscess, patient not having tenderness or pain on loss of protective sensation. So these all may be absent. So diabetic foot infection, these are the signs of, and this is the IDSA, Infectious Disease Society of America guidelines for diabetic foot infections, 2012. No signs of infection. Then grade 2, the cell lattice should be less than 2 centimeter. Always remember around the ulcer. Then moderate to severe cell lattice more than 2 centimeter plus one of grade 2 signs such as abscess, fasciitis, septic arthritis, and osteomyelitis. And of course, SIDS or grade 4 when the patient is in severe sepsis. This is the mild diabetic foot infection. You can see this is one of the infection, paronychia or abscess of the dorsum, and this is a moderate D5. It looks like iceberg phenomenon, small, but it's a deep-seated abscess, and you have to need a diabetic foot exploration in these patients. And these are the severe diabetic foot infection. These may be even sometimes limb-threatening or might be life-threatening if not taken care properly. This is the diagnosis of osteomyelitis. Foot X-ray, one of the very important. You can see it. Sometimes X-ray may be normal. You can have a sausage like toy, which is diagnostic of osteomyelitis, and do a probe to bone test. And probe to bone test, I'm going to show you. Then it's a confirmatory. And if you find X-ray is normal, probe to bone test you are unable to do, then X-ray finding plus ESR more than 70, then it is a diagnostic of diabetic foot osteomyelitis when in comparison with X-ray and probe to bone test and sausage like this. So how you perform a probe to bone test? Just take a probe, sterile metal probe, and you touch from the ulcer side, and if you feel a gritty feeling, then it's a positive. So this is a very good and very simple tool to diagnose osteomyelitis. Osteomyelitis is a serious complication of DFI, occurs in 20% of mild to moderate infection and occurs up 60% in the severe infection. It should be suspected in any infected deep or large foot ulcers when the ulcer is localized to a bony prominence of the foot. MRI is definitely not doing it routinely because the most of the patient doesn't require it. Only plain X-ray, bone to probe test, PTB, probe to bone test, and then ESR more than 70. Sometimes CRP and procalcitonin also helps, but CRP, the ESR more than 70 is one of the clue that you can think of diabetic foot osteomyelitis. How about the antibiotic? These are the different factors. Severity of the infection, it's a mild, moderate, or severe, or you can divide it like this: non-limb threatening, or life-threatening. Etiological agent, antibiotic therapy, bone infection, vascular status, allergy to antibiotics, renal and hepatic insufficiency. Because most of the patients who are in diabetic foot infection, their creatinine is raised, or they are having either AKI or uh, uh, CKD or AKI or AKI on top of CKD. So these patients, you have to look into that dose of antibiotics and regarding the choice of antibiotic. Especially, I'll suggest one thing, that aminoglycosides should be avoided in this group of patients. Then non-limb threatening or mild, moderate, severe, always start with antibiotic combination, which is in coverage for both gram-positive and negative. So gram-positive, most common is, as I've told you, the staph, then streptococcus. You can start with a combination of amoxicillin clavulanic acid with a quinolone, levofloxacin, or you can give a ciprofloxacin combination. If it is limb threatening, start with piperacillin tazobactam. This is there, plus linezolid. Linezolid is not just like I think they have got a brand name by the Lijo Force something. What if I'm right? So this is very economical brand. Mankind is just doing a service to the mankind. So that is one. And if it is life-threatening, then you can start with the same combination. You can start with the meropenem plus teicoplanin. Before starting antibiotics, please try to send a deep tissue culture, not the superficial culture or pus culture. Deep tissue culture. First, debride the wound, take the deep tissue culture, sand it, and start it. And according to tissue culture sensitivity, you can escalate the antibiotic therapy or you de-escalate the antibiotic therapy. So, what is the take home for the antibiotic regimes? Begin empirically and revise based on results of culture. Aminoglycoside should be avoided. Topical antibiotic having no role is not. Antibiotics are not recommended for clinically non-infected neuropathic foot ulcers. Temperature measurement is a glucometer of the foot. Now we all know the screening done in this COVID time or pandemic time. So this is the infrared thermometer which is available. And if the difference in temperature is more than 2 degrees in these 2 feet, then you have to suspect that is a cellulitis or it's a Charcot-Foot or any other thing. So this is a glucometer of the foot. So always have a infrared handheld thermometer. Then to measure the plantar pressure, most important is the Harris mat. Just ask the patient to stand up and see the high pressure area. This is one of the way you can measure. And first scan, it is not required in routine, but I'm just going to show you. These are the high pressure areas. And after giving a insole, the pressure areas has been reduced and redistributed, because in the midfoot we know there is no pressure, but it has been redistributed by giving a triple layer midfoot arch support, and it has been done in both the feet. So this is a foot scan which we are using. Then most common, we all know there are a lot of classifications. One is the Wagner's, which is oldest, then the University of Texas, and then recent the Wi-Fi classification, wound, ischemia, and foot infection. This is the Wi-Fi classification. This is a very good classification. You see for the wound, you for the ischemia, and go for the foot infection. But in clinical practice, most simple is you use the Wagner's classification. Means superficial ulcer, deep ulcer when you will call when the depth is more than 3 millimeter, then grade 3, which is ulcer with osteomyelitis, involvement of bone. Grade 4, then when there is a localized gangrene, and grade 5, there is extensive gangrene. So this is the most common and simple classification. Then how you manage. About the offloading modality, we have discussed about neuropathy, we have discussed about adequate about the vascular status or peripheral arterial disease. We have discussed about the infections. Now the offloading modalities. So removable devices and removable devices. Total contact cast is the gold standard. TCC with window and instant TCC. The most modified posterior slab we are using a lot. Crow, and this is the indigenous offloading technique which we have also developed based on the principles of Samadhan system, which we are all are using. So you see, is a 4-foot offloading outer sole modification. This is the known as the indigenous technique of offloading. We have taken. I'm going to show you. This is ulcer. So one here and another here. So it is offloaded. There is no pressure on the ulcer. So these are the footwears where you. This is a total contact cast. Is a modified posterior slab, and is a total contact cast with window for regular dressing. So these are the different offloading modalities. And in our country, most of our patients, 85% are neuropathic ulcers, and the most common problem which we are facing is the absence of offloading or inadequate or inadequate offloading, which is the most important cause of non-healing of ulcer. You can do often external offloading shoes, forefoot, midfoot, and hindfoot. But whenever you use the hindfoot offloading, please ask the patient to walk with the walker, otherwise he will fall down. So that is it. It is a total contact cast. SK offloading. Take a piece of foam, roll it, wrap in a piece of gauze, and stuck with a micropore. And this is the way. And it can be practiced at the primary care center, for about secondary or tertiary. And even the family members can do it. And it's a very good modality. With the modified footwears, if you use, most of the ulcers are going to heal if the diagnosis is correct. So that is very important. So this is the way how you can use it. So with this background now, I've discussed all the basic principles of diabetic foot management. So now with the case discussion, this patient is having, you see, multiple ulcers, one here, another here, and one here. So barefoot walking the temple during hot climate, and you see right foot, and you see area of ulceration. It is on the plantar surface. You see, this is again on the plantar surface. These are, and so it is a neuropathic ulcer, and a lot of callus around it. You can see. So these are the neuropathic ulcers. Very important. And you see there is a digital fungal mycosis, nails. You can see the size of nails. This is like that. So what you just debride in your clinic, because there is loss of protective sensation, it doesn't require any OT setting. Take a blade and blade handle and just debride it. So this is one. And after debridement, you see the ulcers. It's looking clean and very good, granulating tissue, and blood pressure, ulcers with callus and dead tissue, monofilament, and the biothiometer was grossly impaired. Both the pulses were palpable. ABI was normal. Probe to bone test was negative. So there was no osteomyelitis, but the grade 2 ulcers, except the both feet were normal, and these were there. So most of the patients are in very poor control of glycemic control, 10.6. Creatinine was normal. And so what we have done in one side, we have given a SK offloading here to heal these ulcers, and other on the grade 2, we have given a posterior slab. So you see here is the posterior slab has been given, and a insole. This is the insole where this the window was made for the dressing. So this has been given, and you see at 4 weeks and at 15 weeks. So ulcers which were not healing since a year has been healed in just 4 months. So only problem in this ulcers which were not taking care was the offloading technique, because debridement, infection control, vascularity, adequate vascularity, and then the offloading. These are three basic principles. Whenever you treat a diabetic foot ulcer, always remember these three are the most important part. Then this is another case where history of tobacco addiction, blackening of third of right foot, with severe pain. Also lateral bord of the great toe also. This is there. And you see history of traumatic injury 5 months back. Both posterior tibial and dorsal pedis were absent. Popliteal was present and it was feeble. So it means left foot, both posterior tibial and dorsal pedis were present. These were the weight, height, and other things. Then investigations, A1C was again very poor control, and the very important creatinine was also 1.4. So EGFR around 45 or like that. So ABI was not recordable in the right side. You can see it, while in the left it was 1.2, and TCPO2 regional perfusion index was 0.29. Means there is very low probability to have healing of this ulcer. So CT angio has been done, and which was showing near total occlusion of right popliteal with distal arteries reformed by collateral. So patient is lucky that patient is having a total occlusion of right popliteal artery, because in diabetics we know it's a trifurcation, means anterior tibial, posterior tibial, and peroneal or fibular is more commonly involved. So that is there with gangrene third order, type 2 diabetes, and hypertension. So PTA was done to right suprafemoral artery, popliteal artery, and right anterior tibial artery. And after that, the ABI, which was very low, become 0.9, and TCPO2, which was 0.29, become 0.41 after 1 week. And after angioplasty, vascularity was improved. Amputation of third toe was done. Operating, it was noted that fourth toe also infected and discolored. You see, the discoloration of the fourth toe is also there. And patient was put on insulin, aspirin, atorvastatin. Always remember, these patients should be put on high dose statin or intensive statin therapy, 40 to 80 milligrams of atorvastatin or 20 to 40 milligram of rosuvastatin. Remember it, very important. So even we found the fourth toe is also blackening. So we have done a amputation, and then the closure has been done, and the ulcer healed at 4 months, and patient pain have relieved. So this is another case, admitted outside and treated for cellulitis. You see, or the right foot, you can say ankle and foot, and history of trauma not there, cause not known. Hypertension for 2 years, obesity, obstructive sleep apnea. Patient was on ICD and hypothyroidism. These are the associate comorbid conditions in these patients. Blood pressure was this much. Blood pressure, pulse, swelling, redness there. Local temperature was raised. It was around more than 4 degrees, and both the pulses were palpable. So in this setting, we have to think of Charcot's foot, because when the other causes, just like deep vein thrombosis, cellulitis, gouty arthritis, and all these excluded, then a high index of suspicion is very important to think of Charcot's foot. So local temperature, oh my God, not 4 degrees, it was 7 degrees difference. And X-ray shows chronic osteomyelitis with Charcot change. It was not osteomyelitis, basically it was Charcot's foot. And CT revealed Charcot's with foot with features of chronic osteomyelitis and disc articulae and hind foot. So you see this bones has been totally destroyed here. You see even the this calcaneum is there, and the tarsal bones had been gone. And you see this patient was immobilization, surgical fixation, IV, antibiotics, pymidonate infusion, and it was a chronic situation, so that's why we've done. And total contact was given when the temperature came down to less than 2 degrees. Then patient was sent from here. Nobody is ready to operate to Mumbai, and Dr. Bal performed this surgery by inserting 3 screws in metatarsal talus and calcaneum. Patient recovered, and patient has good quality of life. After surgical fixation, put on TCC for 4 months. Temperature difference below 2 degrees with contralateral foot. After 8 months, AFO ankle foot orthosis was given. But very important, recently, after recovered so much, after just completing everything 1 year back, I heard the news that patient had sudden cardiac death and passed away. So a very high important message is high index of clinical suspicion. Suspect in uh, any patient with neuropathy present with red hot and swollen foot. Pain and discomfort may present despite neuropathy. Differentiation from other possible diagnosis is important, and temperature measurement is a very important aspect in these patients. So this was at presentation at after 8 months. So this is the another case in the heel area. Heel ulcers heal very difficulty, huge ulcer and more than 3 years non-healing. And you see mechanism of injury, cracked heel. If you remember, I've shown you one photograph of cracked heel followed by barefoot walking, surgical debridement, skin grafting, followed by non-healing ulcer at a heel area. This is the skin grafting which has been done and advised for amputation. This patient was advised for amputation. Came to us and we have sent the wound culture, showed growth of staph which was there, and A1C in this patient were luckily 7.5, creatinine 1.3, and there is a bony erosion of the calcaneum was seen here. You can see, and this patient was ABI was normal, and long-term callus shaving was done, long-term antibiotics. Here, actually, in that situation, we plan to give the rifampicin plus the uh, quinolones, but patient doesn't agree for that because patient was in the past, there is a history that he had anti-tubercular drugs, so he had severe reactions. So we have given clindamycin and moxifloxacin for 1.5 months, 6 weeks. Actually, initially we used to go for 3 months. Initial recommendation was you can give the for osteomyelitis up to 3 months, but nowadays recommendation is up to 6 weeks. But in few patients, or still we are using up to 3 months antibiotic therapy. And modified window walking total cost has been given, and family members were trained for regular dressing with window. So this is the presentation, and this is the total contact cost with window we have given. And then you see after 11 months and after 19 months. So this ulcer become healed after practically 1.5 years. So patient should have patience, family members should have patience, and even the treating physician should have a patience. So very important. This is another diabetic foot infection, injury to ankle, 15 days, followed by hot back compression. She was in severe pain, so she have done the hot compression. And you see X-ray, no bony involvement, you can see it, and the lower limb revealed normal steady color Doppler. Hemoglobin is very low, blood transfusion is given, and the counts were very high. Patient was given meropenem and teicoplanin, and creatinine was 5.5. So it's very high. It's AKI, and transfusion, antibiotics, and acute kidney injury, and extensive surgical debridement has been done, and then the silver dressings has been applied, and the vac has been put. This is the vac therapy, repeat debridement, and then the bed is prepared. After vac, the surgical this grafting has been done, or split skin grafting has been done. So regular dressing continued, and patients healed. Wound closure at 12 weeks. So you see, it needs a lot of effort and it's a teamwork. If you will ask me that I can treat diabetic foot, no. As a team, we can treat the diabetic foot, and the team leader or captain of the team should be a diabetologist or endocrinologist or physician, not the surgeon. So, dear friends, diabetics should treat their feet like they do their face. This is a very, very important point I want to convey them. And it's a teamwork. And what are the members? Diabetologist, surgeon, plastic surgeon, vascular surgeon, podiatrist, nurse practitioners, and even the family members are the a member of the team in the diabetic foot care, and patient himself. So patient himself, family members, nurse practitioner, podiatrist, diabetologist, surgeon, then vascular surgeon, plastic surgeon, everybody is the team member, and then only you can win the match. So these are the most common foot care instructions we have to provide to avoid the amputation. Do not walk bare feet. This is a take home. I can say, do not walk bare feet. And whenever a patient comes to you, please ask him to remove his shoes and socks and examine their feet. And start your examination from apadamastak, from feet to head. That is very important. These are so, dear friends. To summarize, nothing supplants the role of good basic wound care. That is the proper debridement and infection control, then the management of peripheral vascular disease or adequate vascularity, and the proper or adequate offloading. Management of infections, wound change over the course of treatment. Be prepared to change your therapy as the wound characteristic changes. Stopping ulceration not always possible. Preventing ulceration from progression to an amputation certainly possible with aggressive wound healing modalities. Pay attention to the basic tenets of wound care. After all, it does not matter what kind of advanced therapy used if you have not paid attention to the basic tenets of it. Thank you very much for giving a patience hearing. It's a long talk. So if anybody who is having questions, comments, and everything, so I'm happy to take all that. Thank you very much.
Thank you, sir. Thank you for this wonderful session, sir. And I believe, I mean, you have actually taken care of all the aspects of diabetes foot management, sir. Now, sir, if I just check, sir, the question,
Yes.
sir, the first question, I mean, people wanted to know is that how to prevent it? What are the, if in a single line or in a single 1 or 2 line, I mean, if we want to know how we can prevent diabetic foot progression?
So very important, prevention of diabetic foot. I told you there are 5 things. One is annual screening of the feet, which I've shown you. If you will go for an annual comprehensive foot examination, loss of protective sensation or biothiometry or pedal pulses palpation or ABI1, then patient education, very important. That if patient, you will ask that please do not walk barefoot if you have got a loss of protective sensation or you have got neuropathy. Don't walk even indoors in the house. You please wear the indoor slippers. That is very important. And then the self-examination of the foot. We even sometimes the plantar surface patients are not able to see, so we ask them to take a mirror and examine it. And proper footwear, which is very, very important, because proper footwear, when to purchase in the evening, because the foot swells in the evening, very important. And both the feet to be measured separately, because footwears are available in the number of 7, 8, 9 like that, but we find in some one feet is 7 and another is 7.5. So you have to purchase 2 footwears of different, so that is there. So these are very minor things but very important. And the footwears, these are the one is, you see, customized footwears only require hardly less than 5% of diabetic foot patients. Most of the patients require the diabetic footwears, which are, if you will have a good insole, which reduces the plantar pressure, a good toy box having adequate area, low heel, and the external sole should be good and tough, so the foreign bodies will not go. So these things will happen. And the regular education, because education may be in the groups, maybe on the one-to-one, and this, so do's and don'ts. We say do's means you do not do the just like what we have shown. I've shown a case where he have done the hot fermentation. So that is the things. So all these things lead to the prevention of foot ulcers. This is there. So these are the 5 things which are there, and according to International Working Group on Diabetic Foot, these are the guidelines. If you follow these, then the patients will not have much of the ulcer, and you can prevent the ulceration. You have to prevent the aspect: education, footwears, and then regular inspection, and the comprehensive foot examination every year. These are the points.
Thank you, sir. So the next question is, I mean, sir, other than regular anti-diabetic medications, what is the role of methylcobalamin in prevention, sir?
Actually, frankly speaking, methylcobalamin has not any role in prevention of diabetic foot.
Okay.
Because only thing is, diabetics are mostly on metformin, that's the first line drug. So we all know it causes depletion of vitamin B12. Some say how this, forget about all these mechanisms. Only thing is, these patients are in, some patients are in neuropathy. There's a B12 deficient neuropathy. So it will help in improving the symptoms, but prevention of diabetic foot, it is not in any role.
So, sir, not in prevention, as you suggested. I mean, but for the for lowering the symptoms, it has some role.
Actually, some studies say yes, it helps. Some say no. But if you see the recommendation from any guidelines from ADA, RSSDI, or you can say ESD, no guidelines. Only thing is, you measure the B12 levels. If it is low, you replace it. So it will avoid the neuropathy. That is one.
Thank you, sir. So, sir, so to elevate, I mean, to reduce the neuropathic pain, what is your suggestion, sir?
You see, 2 things here I just want to mention. One is about the painful neuropathy, another is painless neuropathy. Okay, so painful neuropathy, it is the C fibers, which are small fibers or unmyelinated fibers, what happened? These carries the pain sensation. Initially, there is a painful neuropathy, and painful neuropathy is really nightmare for the patient, for the treating physicians, and all. When the condition worsens from painful to painless, patient says, yes, I'm improved. But practically, he's worsened. So there are three things which you remember. One is pregabalin, which is approved for the pain management of painful diabetic neuropathy. Another is duloxetine, and another is the gabapentin. So FDA approved pregabalin, duloxetine, and the gabapentin has been also recently approved. The doses which we are using, generally the recommended dose is 300 to 600 milligram per day. And we know the side effects of pregabalin. We are using just starting with the 75 milligram, or maybe sometime half tablet of 75 milligram, and gradually you build up the doses. So we all know what are the side effects: drowsiness, somnolence, vertigo, pedal edema, all these. So I'm maximum using 4 tabs or capsules, means 300 milligram per day, pregabalin, twice a day initially, but I start maximum with 75 milligram, maybe 37.5. I start with duloxetine. Recommended dose is 60 to 120 milligram. In our scenario, we are either using 20 milligram or 30 milligram, but I'm use maximum 60 milligram. So that is there. And there is a lot of study. People think that a combination may help, but sometimes the combination may also not help. And about the gabapentin, the recommended dose is very huge. It is from 1800 to 3600 milligrams. But in clinical practice, people are using 100 milligram, then 300 milligram, or 300 milligram twice. So it's a low dose. But probably we Indians are responding better with the low dose. So might be, but it's very difficult to treat. Local application of lignocaine, local application of this gabapentin, a lot of things are there. But it's really sometimes very difficult to handle the patient with painful neuropathy. But of course, this is the time, and preventive foot care is very important to have a good foot wears to avoid the foot ulcers.
Thank you, sir. Thank you very much, sir. That was the last question, and really wonderful experience, sir. Going through a whole complete workshop, and I'm sure our audience must have really enjoyed all the talks, sir. So thank you very much, sir. Thank you.
Yeah, thank you, Prasant. Thank you to Team Mankind. Thank you, Ravisha, Rana, and Tapan, the
Yes,
person in Calcutta, and a whole team of Mankind. And thank you all. Please be careful and take care of your health, and of course your family. So thank you very much. Good night.
thank you, sir. Same to you, sir.